Hi, my name's Amy. I'm a registered nurse for Dr. Duncan Taylor, who's a plastic and reconstructive surgeon in Perth, Western Australia. Deciding to undergo breast reconstruction surgery can be a very emotional process. We hope to provide with these videos information for you to make informed decisions with confidence. Dr. Duncan Taylor will now discuss some common questions patients have after they've been diagnosed with breast cancer. This includes, when should I see a plastic and reconstructive surgeon for an initial consultation? What happens if I require radiation therapy? And will I require a breast reconstruction if I have a lumpectomy? Watching this video will help answer a few crucial questions patients have in relation to their breast reconstruction journey.
My name is Duncan Taylor. I'm a plastic and reconstructive surgeon, and I have a subspecialty interest in breast cancer reconstruction and breast aesthetic surgery. Ideally, anyone who's having a mastectomy for breast cancer diagnosis would come at the very beginning of their cancer journey. So really immediately after a diagnosis is made, then it's preferable to see the patient to discuss the options which are available to them and to be able to have a review of their situation and what may be best suited. It may be that the surgery for the reconstructive surgery component is not suitable right at the beginning at the same time as a mastectomy, or maybe that the surgery may benefit from a different form of reconstruction further down the line. But it is ideal to have that information to make an empowered and informed decision right at the beginning. Unfortunately, radiation therapy to the reconstructive surgeon generally always causes a detrimental effect. Obviously, the primary focus in all of breast cancer management, including reconstruction, is the oncology. And the oncology comes first, so the breast cancer treatment comes first, of course. If you require radiation therapy, sometimes this is known about before the surgery, before a mastectomy. Sometimes it's only determined after the breast has been removed and has been sampled for the cancer and the histopathology has been able to be processed, but also including lymph node sampling, which most commonly is in the armpit or the axilla. If you have had a reconstruction, whether that be implant-based or autologous reconstruction, then the radiotherapy will have some effects upon that. It doesn't always mean the reconstruction is doomed to failure, but it does mean that the soft tissue envelope and the tissue or implant, which is underneath the skin, will have effects as a consequence. The short-term effects cause an inflammatory response within the tissue, which is a desired effect because it is used for an oncological effect, so we're aiming to try and kill cancer cells. But that causes an inflammatory effect which increases wound healing problems and effects on the capsule which is around the implant. In the short term, that can mean that the implant becomes exposed, or the capsular contracture effect in the relatively short term becomes significant enough to require removal of the implant. Over a longer period of time, the effects continue from a life perspective, and anybody that has radiation therapy with an implant, the capsule will become thicker and it will contract, and it will always require some revisional surgery. Generally, it's preferable to perform the autologous reconstruction after the radiotherapy has occurred, And there's two timings in which the autologous reconstruction can be performed. It can be performed in the after the short-term effects of the radiation has finished, which is around 6 weeks. But often this is a time where the soft tissue envelope still may not have settled down and the skin changes may not have settled down. So this is technically feasibly possible. The more common timing for autologous reconstruction following radiation therapy is after 6 months, when the tissues have softened and settled and the acute effects of the radiation have reduced, including the effect on the blood vessels in the chest, and this then has a more consistent and reliable outcome from autologous reconstruction. If you're known to require radiation therapy prior to having a mastectomy, this would occur related to the severity of the breast cancer, and possibly if the nodes are identified in the exit to be positive with disease. Then there's a discussion to be had with the breast surgeon and the oncology team, medical oncology and radiation oncology. The options essentially in this situation would be either a simple mastectomy, which would mean removing of the gland of the breast and a skin envelope, and there would be no breast, so it would be a flat reconstruction on the chest wall. Reconstruction then can happen after all of the cancer treatments have occurred. And sometimes this is a better situation than trying to do immediate reconstruction, which would be affected by those cancer treatments, principally radiation therapy, in the very short term. You're saving your best options for later. An alternative to that is the use of a sacrificial implant or a temporary implant, where we're still hoping to keep the skin envelope of the breast in knowledge that it will be have radiation treatment to it, so it'll be affected, but the overall reconstruction will not be affected. So the implant is placed in at the time of the mastectomy and the wounds are closed. Radiation and further on cancer treatments occur, and then a more definitive reconstruction, which generally would be autologous reconstruction or your own body reconstruction, can occur some months later after the tissues have settled down. This has the advantage of preserving the breast envelope such that the tissue which is used subsequently fills that shape and fills that envelope in a more natural breast shape. But it does have the disadvantage that there is a higher complication rate from the initial sacrificial implant in terms of wound healing, breakdown or infection in the short term, in the first few weeks following that. If you are able to have breast conserving surgery as part of your cancer treatment, and that is a wide local excision or a lumpectomy and radiation treatment afterwards, then the reconstructive options are different. They don't require a complete reconstruction of the breast, but yes, you can have a form of reconstruction to reconstitute the form of the breast. This is often done in a secondary setting. It wouldn't be done at the same time as surgery, and it would be done some months following, after the tissue is settled and we know the end outcome. The differences in relation to wide local excision radiotherapy in terms of what can be done relate to the size of the breast. If in a small breast the deformity created by a wide local excision is often more significant than in a larger breast, and there is different techniques to be used by the breast surgeon in order to optimize that result. Secondarily, however, procedures can be performed to move the breast tissue around, to be repositioned to reconstitute the shape of the breast, or even tissue can be transplanted into the breast, such as fatty tissue in the form of fat transfer or fat grafting, to reconstitute the shape and contour of the deformity which is produced from the wide local excision.
We hope these videos have been a valuable resource to you. For more information about what breast reconstruction options and resources are available to you, please visit Dr. Duncan Taylor's website for more information.